number. 2/3 of them had more than half a diopter of astigmatism. And 42, so almost, close to half of them had more than one diopter of astigmatism. So astigmatism is real and is a significant problem. And how much of astigmatism matters? Like I said, there has been debate that should you treat astigmatism more than 1.5, 1.5, so on and so forth. And to do that, again, we did a study of over 2,000 eyes where we divided patients into groups having less than 0.5, 0.5 to 1, and more than one diopter of astigmatism. And we found that any astigmatism of more than 0.5 diopters affects the contrast sensitivity, the reading acuity, and the reading speed, even when they are corrected on their spectacles with that astigmatism. So why consider toric IOLs when there are so many other options like limbal relaxing incisions, like LRIs, like opposite clear corneal incisions, like making an incision on the steep axis, so on and so forth. Toric IOLs, because first of all, they are a component of what we are doing anyway. So apart from just placing the IOL at a particular axis, there is absolutely nothing different that you need to do in the entire surgery. The astigmatism correction is definitely more accurate and more permanent and predictable. So unlike LRIs which can regress over a time, you are not sure how the cornea is going to heal based on the age of the patient, the vascularity, so on and so forth. This is definitely more precise and more accurate, and there are no chances of any regression. The biggest hurdle that most of us feel while starting toric IOLs is that we get intimidated with numbers and we feel that we need all the possible diagnostics, equipments, and how do I calculate and how will I convince the patient and so on and so forth. So let's see what are the things that we find useful when we started implementing toric IOLs as a routine in our clinical practice. I think there are three basic points that all of us need to look at. First is to understand the kind and the type and the total astigmatism that the patient has. Once you do that, now you need to measure it correctly, and then you need to implant the toric IOL at the correct axis. And let's go step by step. Understanding the astigmatism. So the astigmatism is not just what you measure. Remember, you are going to do a surgery, and that is also going to change the astigmatism. You may induce or reduce some astigmatism from case to case. So the astigmatism can be divided into two components. First is the pre-existing astigmatism, and second is the surgically induced astigmatism. And each surgeon must calculate his surgically induced astigmatism. Fortunately, with all the work that Dr. Graham Barrett and Dr. Warren Hill have done, surgeons using 2.2 or 2.4 millimeters incisions can safely use an SIA of 0.1 without actually having to calculate your own SIA. And that is because now more emphasis is given to the centroid value of SIA rather than the mean or the median. Again, this is the most common or most debated thing, that because the astigmatism is with the rule, I'll operate with a superior incision, otherwise I would have operated with a temporal incision. It has once again been shown with extensive work done by Dr. Warren Hill, Dr. Graham Barrett, Dr. Holliday, Dr. Abulafia, that each incision, each size will have a different SIA, because astigmatism is not just magnitude, it is a vector. It is magnitude as well as direction. So on axis and off axis is not something that we must be considering, and try and keep your incision as stable and do it on a consistent basis from the same location. How do we measure keratometry, or how do we measure astigmatism? Ideally, you must have at least more than one measuring device to actually confirm the magnitude as well as the axis. Manual keratometry still holds gold standard and can be used as the first line, but you must have at least one or the other form of either auto keratometers, particularly the newer optical biometers like the Lenstar, IOL Master, Tomy, so on and so forth. And the second thing that you need to confirm is whether the astigmatism is regular or irregular, because remember, toric IOLs or any form of astigmatism correction devices can correct only regular astigmatism and not irregular astigmatism. And to measure regularity or irregularity of astigmatism, you need either topography or tomography based devices like Placido based topographers or Scheimpflug based devices. Few years ago, Dr. Douglas Koch in his landmark article here questioned the way we measure corneal astigmatism. And he brought about, very importantly, that we are all not considering what the posterior cornea is telling us, or we are not actually measuring the posterior corneal astigmatism. There are now, because now there are devices which can measure that, he did a study on several thousands of eyes, and to broadly generalize came up with a nomogram. That if the patient has with the rule astigmatism, you need to undercorrect it by 0.3 diopters. That is because the posterior corneal is against the rule, posterior cornea, and in against the rule astigmatism, you need to overcorrect it by 0.3 diopters. So this was the broad generalized nomogram that he came up with a few years back. Now, to factor in the posterior corneal curvature, there are various ways. Either you can directly input if you have access to tomography devices like Scheimpflug, like Galilei, like Pentacam, or you can use these, nomograms, like the one I showed you, the Baylor nomogram or the Abulafia-Koch formula. Fortunately, Dr. Graham Barrett has made life extremely easy for us, and in his new Barrett Toric calculator, it has an inbuilt sort of insurance for the posterior corneal curvature for each eye based on his own mathematical model. So now we don't really need to measure or even actually bother about what the posterior corneal astigmatism is doing. We just need to enter it into the Barrett's Toric calculator. And I think this has actually changed the entire way Toric IOL is being practiced. We cannot be, thankful enough to Dr. Barrett, who has put this up all for free for everyone to access on the APACRS website and the ASCRS website. So this is his Toric calculator, the algorithm where you enter all of the data, and based on which he will give you what is the best option for this patient. So it factors in the posterior corneal curvature, the axial length, lens thickness, anterior chamber depth, and it has been calibrated for most commercially available international IOLs. A further modification, and this is very important, of Dr. Barrett's calculator is the K calculator version, which is also available now free online. Is that for people like me who get confused that I have 3 devices, all 3 are giving, one is giving 10 degrees, one is giving 0 degrees, one is giving 175. Which value do I take up? One is saying 44.1, one is saying 44.3, which magnitude do I take? So to average out all of this, Dr. Barrett has come up with the K calculator where you can enter values of up to 3 different devices. And he has standardized it for about 10 different instruments which are commercially available right now. And based on whatever you input, the vector calculation will average out and will tell you what would be the ideal for this patient. So now you even don't have to bother about selecting a perfect reading for that particular patient. You can enter all the data that you have, and the calculator will do all the work for you. And most newer company calculators have also incorporated this. The Alcon Acrisoft Toric calculator has also incorporated the Barrett's Toric calculator algorithm into it, so you can even directly access the company websites. And if you have access to LensStar, the LensStar also comes with the Barrett Toric suite. So you don't even need to go online or go anywhere to enter the data. Whatever data that is captured from the LensStar, it will already give you with the axis placement and the model of the Toric IOL to be placed. So I think calculating has become quite easy. There have been various literature reports now showing that actually incorporating or adding the posterior corneal curvature value from what you calculate from Pentacam is inferior to using the new Barrett Toric calculator. So like I said, you don't really need to measure or worry that you don't have Pentacam or you don't have Galilei and you can't measure the posterior cornea. Now since we have measured, and now we have to actually go on and perform the surgery. And to align the toric, the first step that all of us need to do is to mark the patient. Having tried different devices, we find the freehand marking to be as good or as bad as any other marking device. And the trick is to make sure that the limbal area is dry. We ask the patient to sit and look at a distance target, and whatever we feel is 0 and 180, we actually mark that. You may not necessarily need to make 3 marks, but you can make 2 or 3, whatever that you find. With the era of newer fancy imaging devices, with newer cameras, with newer photo slits, there is this very simple app designed once again by Dr. Graham Barrett known as the Toric Cam app, which is available right now only on the App Store. But it uses the iPhone's gyroscope. That is, it measures, you take a photograph of your marking and it will tell you how much above or how much below you are actually to your 0 degrees. So although here I felt my nasal mark should be 0, it's actually 2, not 0. And for example, here it's 178. So the Toric Cam app is a useful device which helps us to evaluate our own markings, and you can use this adjustment intraoperatively that you are 2 degrees already off and align them accordingly. Intraoperative surgical toric IOL alignment is actually not at all intimidating. Once again, some steps that you need to follow. First is to make sure that before you actually do the marking, you must dry the area where you are going to place your Mendes ring, because sometimes fluid can seep in through this and blotch your marks. Once the area is dry, you can use this and make either 1 or 2 markings. With the parallax, it's impossible to align your toric IOLs on both sides. Therefore, we have now stopped marking on both sides and mark only on the proximal side to the surgeon's eyepiece view. Once that is done, you place the IOL, and once the IOL is placed, we actually have stopped rotating it before actually removing the viscoelastic. So the traditional teaching is to rotate it until it is about 20 degrees close to the pupillary axis. But with bimanual irrigation aspiration, leaving the IOL in this direction makes it a lot easier to remove the viscoelastic from behind the bag. And it's very critical in toric IOL cases to remove all the viscoelastic from inside the bag so that there is no rotation of the IOL inside the capsular bag. Once all the viscoelastic is removed, you can use the same bimanual IA as your dialers. So you reduce your parameters to the lowest vacuum and the lowest flow rate to basically polish parameters. And then you can use your irrigation or the aspiration handpiece to dial the toric IOL into place. The good part about toric IOLs, particularly with the Acrysoft platform, is that the post-operative rotation is very minimal. So whatever you leave behind, you're going to leave it, it's going to be there at the end. Always make sure in toric IOLs that the eyeball doesn't, the globe doesn't, the chamber doesn't collapse. So always hydrate your wounds before you remove your irrigation, because some forward movement or sudden shallowing of the chamber may lead to some rotation of the toric IOLs. And now there are intraoperative imaging devices like this particular one, the Varion that we have access to, where it takes a photograph starting before surgery, which it compares with the pre-operative measured photograph. And once that is done, you don't actually need to make markings while IOL placement. It also helps us in making our incisions at the correct location. What we feel 90, 180 or at 10 degrees, we can exactly make incisions at that location. And finally, aligning the IOLs, you can, these marks help us to align it like manual marking. So they've improved the efficiency of doing that. And there is literature to support that cyclotorsion is better compensated with these imaging devices than with our manual marking devices. And what the keratometry, the Varion measures is compared to the gold standard keratometry measuring devices right now. Further IOL misalignment is also less. A further step up moving forward to Varion is intraoperative abrometry, where you can actually real-time fine-tune your IOL placement. So this is the actual measurement in the aphakic mode, that is once the lens is removed, and it will tell us what is the intraoperative refraction, and based on which what IOL power and what toric model should or should not be used in that patient. And intraoperative there is more and more literature coming up that compared to standard biometry, it may actually help us enhance our toric outcomes in the times to come. So to end, I would say that any amount of astigmatism needs to be corrected. Even lower amounts of residual toric IOLs give even lower amounts of residual astigmatism compared to relaxing incisions. However, there will be significant number of patients who will be left behind with some post-operative astigmatism. But any post-operative astigmatism less than about a half a diopter is clinically acceptable in today's time with today's pre-operative and intraoperative measuring techniques. So I think there is no reason why all of us should not incorporate toric IOLs into our day-to-day practice. And believe me, it will help in improving the visual outcomes and the patient satisfaction significantly. Thank you very much.
It's a pleasure that Dr. Ramamurthy has come here in his busy schedule. When you come and start, would you also comment on your tips on toric very briefly before you go to your topic? Dr. Ramamurthy, please. Before he does, I just want to tell the facts that although the 0.5 diopter astigmatism bothers, it is almost impossible to correct that in the present scenario in a patient. So do not be very ambitious or suggest toric lens if the total astigmatism is going to be 0.5 or so. You're likely that you will not succeed. In my enthusiasm, I tried and I failed. Another fact I want to tell you is that it's in about 70 to 75%, some say 80%, but I think 70 plus, that you will have a good targeted refraction in astigmatism point of view. 25% or so